You are providing anesthesia for a 65-year-old male undergoing a right-sided thoracotomy for lung resection. After induction and positioning for one lung ventilation, OLV, oxygen saturation drops to 85% despite FiO2 of 1.0. What are the potential causes, and how would you manage this situation? Answer: potential causes. 1. Malposition of the double-lumen tube, DLT. The DLT may have migrated, resulting in incomplete isolation of the lung. 2. Inadequate lung deflation on the operative side. If the lung is not fully collapsed, it may affect ventilation perfusion, VQ matching. 3. Shunt fraction increase. During OLV, perfusion continues to the non-ventilated lung, increasing the shunt fraction. 4. Bronchospasm or atelectasis of the ventilated lung. Secretion or mucus plug in the DLT or bronchial lumen. Management. 1. Confirm tube position. Check the placement of the DLT using fiber optic bronchoscopy to ensure proper isolation. 2. Optimize lung deflation. If the operative lung is not fully collapsed, consider suctioning the bronchial lumen or ensuring no air is trapped. 3. Increase PEEP on the ventilated lung. Apply positive end-expiratory pressure to improve oxygenation in the ventilated lung, starting with low levels, 5 centimeters H2O. 4. CPAP to the non-ventilated lung. If oxygenation remains poor, consider applying low levels of continuous positive airway pressure, CPAP, to the non-ventilated lung. 5. Check for secretions. Suction the endotracheal tube or bronchial lumen if secretions are suspected. 6. Revert to two-lung ventilation if needed. If desaturation persists despite interventions, temporarily resume two-lung ventilation and reassess before returning to OLV. Question 2. A 58-year-old female with COPD and severe pulmonary hypertension is scheduled for a left pneumonectomy. Discuss the anesthetic management of this patient, particularly focusing on intraoperative monitoring and management of pulmonary hypertension. Answer: preoperative assessment. Evaluate the extent of COPD and right heart function via pulmonary function tests, echocardiography, and if necessary, right heart catheterization. Optimize bronchodilator therapy and ensure pulmonary hypertension management is maximized with medications such as sildenafil or epoprostenol if indicated. Intraoperative anesthetic management. Induction. Slow, controlled induction to avoid hypotension and right heart failure. Agents like etomidate or ketamine may be preferred for hemodynamic stability. Ventilation. Aim for lung protective strategies with low tidal volumes, 4 to 6 milliliters per kilograms, and permissive hypercapnia to avoid barotrauma. One lung ventilation, OLV. Ensure adequate oxygenation using strategies like PEEP or CPAP as appropriate. Consider the use of nitric oxide or prostacyclin for pulmonary vasodilation. Management of pulmonary hypertension. 1. Pulmonary vasodilators. Continue preoperative pulmonary hypertension medications. Inhaled nitric oxide, INO, or intravenous prostacyclin can be used intraoperatively to reduce pulmonary artery pressures and improve right ventricular function. 2. Fluid management. Maintain a balance between avoiding hypovolemia, which can reduce cardiac output, and overhydration, which can worsen right heart strain. Use goal-directed therapy, e.g., stroke volume variation, cardiac output monitoring. 3. Invasive monitoring. Use a pulmonary artery catheter, PAC, to directly measure pulmonary artery pressures and guide vasodilator therapy. Alternatively, transesophageal echocardiography (EE) can be used to assess right ventricular function. 4. Management of hypotension. Hypotension should be treated with vasopressors, such as norepinephrine, avoiding agents that increase pulmonary vascular resistance, like phenylephrine. 5. Postoperative management. Ensure careful monitoring in the ICU, especially for acute right heart failure. Continue pulmonary vasodilators and consider early extubation if appropriate. Question 3. What are the indications for one-lung ventilation, OLV, in thoracic surgery, and how do you manage the challenges of hypoxia during OLV? Answer: indications for OLV, thoracic surgical exposure, required for procedures like lobectomy, pneumonectomy, esophagectomy, and thoracic spine surgery. 2. Control of contamination, for example, in cases of infection, hemorrhage, or massive secretions in one lung. 3. Protection from ventilation injury, such as in cases of unilateral lung trauma or cysts. Management of hypoxia during OLV. 1. Prevention. Preoperative lung assessment. Identify patients at risk for hypoxemia, e.g., those with significant VQ mismatch or obstructive lung disease. Optimal positioning. Lateral decubitus positioning with the non-ventilated lung dependent improves VQ matching. 2. Intraoperative interventions. PEEP on the ventilated lung. Apply low-level PEEP, 5 cm H2O, to the ventilated lung to improve alveolar recruitment. CPAP to the non-ventilated lung. Apply low levels of CPAP, 5 cm H2O, to the non-ventilated lung if hypoxemia persists. Alveolar recruitment maneuvers. Periodically perform recruitment maneuvers to expand collapsed alveoli. Adjust FiO2. Maintain FiO2 at 1.0 initially, then titrate down if oxygenation improves. Revert to 2-lung ventilation temporarily. If hypoxia is severe, resume 2-lung ventilation until the patient stabilizes. 3. Alternative strategies. Selective lobar ventilation. In some cases, isolating specific lobes using a bronchial blocker may improve oxygenation while maintaining surgical exposure. Inhaled nitric oxide or prostacyclin. For patients with pulmonary hypertension or refractory hypoxemia, inhaled nitric oxide may reduce shunt and improve oxygenation. You are performing anesthesia for a patient undergoing VATS, video-assisted thoracoscopic surgery. What are the specific anesthetic considerations for VATS compared to open thoracotomy? Answer. Advantages of VATS. VATS is less invasive, associated with reduced postoperative pain, faster recovery, and decreased pulmonary complications compared to open thoracotomy. Anesthetic considerations. 1. Airway management. DLT or bronchial blocker is required for 1-lung ventilation to collapse the operative lung for better visualization. 2. Ventilation. Use low tidal volumes, 4 to 6 milliliters kilograms, and PEEP to protect the ventilated lung. Avoid high pressures that may exacerbate VQ mismatch. 3. Analgesia. VATS can cause significant postoperative pain despite being minimally invasive. Options include epidural analgesia, paravertebral blocks, or multimodal analgesia using IV opioids and NSAIDs. 4. Positioning. Ensure the patient is correctly positioned in the lateral decubitus position with adequate padding to avoid pressure injuries. 5. CO2 insufflation. CO2 is often insufflated during VATS to collapse the lung, which can increase intrathoracic pressure and affect hemodynamics. Monitor carefully for hypercarbia and manage any cardiovascular effects. Postoperative considerations. Pain management. Regional techniques such as paravertebral or erector spiny plane blocks can be particularly beneficial. Early extubation. Given the minimally invasive nature of VATS, early extubation is encouraged if the patient is hemodynamically stable with good oxygenation.